Good afternoon. Welcome to our CureHHT webinar with Dr. Timo Krings. We're going to be discussing everything brain AVMs today and all the recent advancements in imaging and management. So we're going to wait a few minutes, let everybody pop on until 3 o'clock. Hopefully, I know we're expecting a big crowd today, and hopefully we'll be able to get to all of the great insight from Dr. Krings and answer a lot of your questions. Many of you sent us questions ahead of time, and we're going to hopefully try to get through as many of those as possible. Just a couple things that just wanted to remind everyone. The webinar is being recorded, and you will receive a link to the recording after the webinar. So that'll be available for you to review again and share. We wanted to remind you that it is HHT Awareness Month in 1 month from tomorrow, June 1st, and all month long we're going to be celebrating HHT month, talking about all the awareness that we can do together. We're going to have lots of webinars and Facebook Lives and different activities. So really start thinking about how you can spread awareness in your community, even if it's just educating one person about awareness and getting everybody excited about this opportunity to really let people know what HHT is all about. Even if it's just people in your family that are undiagnosed, there's lots of information we'll have on our website, and we'll be featuring a lot of that on our social media on Facebook and Instagram all throughout the month. So there's lots of things that you'll be able to share with your family and friends and your community as well. So we're really excited about that. And also we have a link on the slide where you can look at ideas for spreading awareness in your community. We always like to talk about our HHT Connect. It's our global HHT patient registry, and this allows HHT patients around the world to share their health information. It's all de-identified, but this allows researchers and doctors to better understand the disease and in order to develop new treatments and one day, hopefully, a cure. So that information's there, and you can find out more about that, of course, on the CureHHT website. We also have our CHORUS, our Comprehensive HHT Outcomes Registry of the United States. If you or your family member are interested in this, again, there's more information on our website that you can find out about that and how to participate and become registered with CHORUS. We are going to be hosting a town hall during the month of June for June awareness, and we're going to be talking all about our centers of excellence, and we're really excited about that. We're going to be focusing on each of those and all of the updates to our centers, all of the changes that are being made, and all of the new guidelines as our centers continue to pop up across the country, to give you some insight as to some that are working on becoming centers, could be in your hometown. It's always been our dream to have a center of excellence in every one of the United States, and we're working really hard to make that happen. So we hope you'll join us for that. And of course, there will always be lots more information coming down the pipeline about that. You can catch that on our social media. It'll be on our website, and probably I'm sure we'll have some emails that come out about all of this too. Also during the month of June, we're going to have Dr. Miles Conrad. Some of you may recognize him. He's our HHT co-director of the HHT Center of Excellence at UC San Francisco. And he's going to be hosting our second annual Ask Me Anything on Facebook Live. This is always a popular one. Dr. Conrad's great at this, and we'll be hosting that on our official Facebook page during June. I think it's set for June 2nd at 7 p.m. Again, we'll have more information coming out about that, but mark your calendars. That'll be a fun one. if you have any questions about this particular webinar or during the webinar, post your questions to the speaker. We'll ask as many questions again as we can get through. Dr. Krings has a very robust session, so we want to give him as much time as possible to get through all of that. Use your chat to interact with other people on the session. And again, as I said, the presentation will be recorded. Now I'm going to introduce Dr. Timo Krings. He is the chair of the Division of the Neurointerventional Radiology. He is director of the Neurointerventional Radiology Center at Lahey Hospital and Medical Center. I'd like to give a little bit of background about Dr. Krings. He studied medicine in Aachen, Germany, during which time he spent 1 year at Harvard Medical School in Boston. After his residency training in neuroradiology in Germany with Professor Armand Thron, he completed a neurointerventional fellowship in Paris, France, and he subsequently joined the neuroradiology division of the University of Toronto as a diagnostic and interventional neuroradiologist in 2008. In Toronto, he served as a fellowship director between 2010 and 2024, and as division head from 2016 to 2021, and was cross-appointed as a full professor of radiology and neurosurgery and as an interventional neuroradiologist at the Hospital for Sick Children. He held the David Braley and Nancy Gordon Chair in Interventional Neuroradiology at the University of Toronto, and until he resigned in 2024 to become the chair of neurointerventional radiology at the Lahey Clinic and director of the Cerebrovascular Center at Beth Israel Lahey Center in Boston, Massachusetts. He's a full professor of radiology at the T.H. Chan School of Medicine of the University of Massachusetts. Dr. Krings has vast experience in both diagnostic and interventional neuroradiology and is able to cover the spectrum of interventional neuroradiology, including pediatric and adult patients. He has trained more than 40 fellows over his career, many of which are now in leading positions all over the world in the US, Canada, Europe, and Asia, focusing his research efforts on imaging and treatment of neurovascular diseases. Dr. Krings has published more than 500 peer-reviewed articles, and he authored 4 major textbooks on interventional neuroradiology, neurovascular anatomy, neurovascular diseases, and stroke. Dr. Krings' leadership in the field of neuroradiology is bolstered by his distinguished grants and awards, including the Scientific Award of the European Society of Neuroradiology, the Lucian Appeal Prize, and the Founders Award in Interventional Neuroradiology of the ESNR. For the development of the neuroradiology program in Toronto, he won the Anderson Award of the Whiteman Barris Award and was granted the Edward Lansdowne Award for Outstanding Teaching in the Residency Program of the University of Toronto and the Gold Medal of the British Society of Neuroradiology for lifetime achievements in interventional neuroradiology. So, Dr. Krings, we really appreciate you taking the time today to conduct this webinar, and we're really excited to have you here today. So I'm going to let you take over.
Okay, thank you so much for this very kind introduction. I will try to share my slides here with you. Here we go. And I hope that people can see everything okay. Now, in my talk within the next 30 minutes or so, I want to discuss a little bit what is new when we are talking about brain AVMs associated with HHT, especially when it comes to novel imaging and novel treatment approaches. But before we go into what is new, we'll go a little bit into like what are the different types of brain AVMs that we can see in patients with HHT, and why is it of importance when it comes to such things as clinical presentation, but also screening. So I have nothing to disclose in relation to the contents of this presentation. As you know, HHT, or hereditary hemorrhagic telangiectasia, is always also called morbus Rendu Osler-Weber, was described more than 100 years ago as a hereditary disease with nosebleeds, telangiectasias, and iron deficiency. However, we know now that there are way more presentations than just nosebleeds and telangiectasias, although these do belong to the diagnostic Curacao criteria to make the diagnosis of HHT. The more dangerous types of vascular malformations that we'll have to know about are, of course, the visceral AVMs, and including the brain AVMs, which is the main area that we will talk about, and having a first degree relative with HHT, given that it's an autosomal dominant type of disease. Nosebleeds related to HHT are related to these telangiectasias that you can actually see very nicely here in the injection of the artery that goes towards the nose. This is the internal maxillary artery, and here are different sphenopalatine and arteries that are supplying the nose. And the cause of nosebleeds are these tangle of vessels that are present here within the mucosa that are more prone to hemorrhage. We will not speak too much about epistaxis today, as the main topic will be the brain AVMs. We will also not talk about the more common neurological presentations in HHT. The most common neurological presentation is actually that you'll get paradoxical emboli due to pulmonary AV fistulas, so that a small clot is actually going from the right heart towards the left heart and can go towards the brain and cause transitory ischemic attacks, stroke, or even abscesses. What we will talk about are mainly the vascular malformations that can present with either hemorrhage or with epilepsy. And we will talk a little bit why they can cause either hemorrhage or epilepsy and how common they cause these types of diseases. What is of importance is that many patients with brain AVMs are asymptomatic prior to becoming symptomatic at one point in time, which means that there is a rationale for screening. And we will discuss also about the frequency of screening later on. What causes HHT? Well, it is an autosomal dominant trait that is at least related to three different mutations, while likely there's also a fourth one here, that are related to molecules that are mainly expressed in endothelial cells and that are of importance for the formation of blood vessels, which is called angiogenesis. Angio for blood vessels, genesis formation of blood vessels. And when we are talking about angiogenesis, we'll have to understand that this is a process that is constantly happening in our body. In fact, on average, every 7 years, all of our blood vessels are kind of renewed. So the blood vessels that you have now will be different from the ones that you will have in 7 years from now. And this, again, is of importance when we're talking and thinking about screening. Angiogenesis is the process where, from a stable, mature vessel, we have a destabilization process that will then lead to either regression of a blood vessel if it's no longer needed, or to angiogenic sprouting, i.e., new blood vessels going towards the periphery. And this angiogenic process is divided, therefore, into two different aspects. The so-called activation phase, where the blood vessel becomes destabilized, i.e., the basement membrane breaks down so that new sprouts can form from the existing blood vessel. And these sprouts go towards avascular tissue, i.e., tissue that is in need of new blood vessel, in need of oxygen. This happens, of course, when we are growing, but it also happens if, for example, I cut myself and I have focal bleeding, and now new blood vessels have to sprout into the area where I had previous bleeding. This activation phase has to be balanced with the so-called resolution phase, where there's a stop of the endothelial cell proliferation, where the basement membrane are reconstructed, endothelial junctions are again reformed, and where we are reverting into a more stable and more mature phase. And why do I discuss so much about these different phases, the activation and the resolution phase? The reason for this is that the so-called angiogenic switch that shifts or proliferating component into the more stabilizing component, i.e., from the activation to the resolution phase, this angiogenic switch is mediated by the gene products endoglin and ALK1 that are deficient in patients with brain AVMs. So if you don't have an angiogenic switch, then you have an imbalance between activation and resolution phase. And this imbalance can lead to structural abnormalities of your blood vessels. And these are your telangiectasias, these are your brain AVMs, and the other types of vascular malformations that can be seen in patients with HHT. Therefore, understanding your angiogenesis will be of importance to understand the genetic reasoning for developing abnormal vascular like structures in not only your brain but also in your lungs or in your mucocutaneous tissues. In fact, back in Toronto, we had a knockout mouse model for HHT, where you can see that on a microstructural level, we have two different types of vascular shunts. You see here arteries. This is a vein. And you can see that we have a direct communication between an artery and a vein. So this is what we call a fistula. A fistula means a direct communication. And now think about an artery that like pulsates, that has very high pressure, pulsating with this high pressure into a vein. And vein, as you know from like just looking at your hands, normally have very low pressure. So if a high pressure system is directly interconnected to a low pressure system, then the vein will start to dilate and may at one point in time burst. The second structural abnormality that we can find in this endoglin knockout mouse are these glomeruli, those nidi of abnormal vessels, a tangle of abnormal vessels. And these are very similar to the brain AVMs or arteriovenous malformations that we can see in patients with HHT. And already more than 20 years ago, when I was still working in Paris, we looked at the different phenotypic, like the different phenotypes in patients with HHT. And we found that there are at least four different types of vascular malformations that can be present in patients with HHT. And this was also demonstrated here by the group in Toronto with my previous co-worker Carl Terbruch, that demonstrated that there are four different types of vascular malformations in the central nervous system. We will talk mainly about the brain ones today, but I first want to mention that there are spinal arteriovenous fistulae. And these arteriovenous fistula are very similar to this arteriovenous fistula in the knockout mouse, mean that a single dilated artery is hooking up to a dilated vein that can then either burst and make a catastrophic hemorrhage, or it can displace the cord and therefore lead to problems of your signal transduction from your brain to your muscles. This type of arteriovenous fistula was mainly present in the younger age group, i.e., the mean age from the French series was only 2 years of age. And we can see in these patients that there's remodeling of the bone, that there's an extremely high flow going into this type of fistula, and that there's a risk for hemorrhage. And they often converge into one single like point of fistulization, which is why we call it a single hole high flow macrofistula. Moving from the spine to the brain. The second neurovascular malformation that we have encountered are the cerebral arteriovenous fistula. So again, a single hole fistula, however, different from the spine. In 50%, there was more than one fistula, again, mainly in the young age group, often a single feeding vessel. And on MR, we can see very nicely this abnormal like vessel that is hugely dilated simply because the veins have normally a low pressure, and now this high pressure is pumping blood constantly into a structure that is only accustomed to have a low pressure, and therefore this vessel dilates and can at one point in time rupture. Here we have a patient where on MR imaging you can see one fistula here, a second fistula here with these massively dilated feeding arteries. And here we have another example. This is a diagnostic angiography where you can see we are injecting into the carotid artery here, and you see that there's one fistula right there, a second fistula there going into this massively dilated pouch. Another example here with one fistula here, a second fistula right there. Multiplicity is classical for patients with HHT. Young age for these type of fistulous malformation is typical, and it is estimated that the rupture rate among children is nearly 1% per lesion per year. And because most kids have multiple lesions, the rupture rate within the first 15 years of life is in the range of like 15 to 30%. So that's significant. What is even worse is that if these fistulae are already present in utero, or if these fistulas are present as a baby, then you may get significant problems with your brain development related to a venous hyperpressure, which can cause to something that has been coined the melting brain syndrome, i.e., where your brain is just not getting enough oxygen and therefore shrinks and gets like no longer functional. As I said, hemorrhage is a major risk in these types of arteriovenous fistula. This is the worst type of like vascular malformation in HHT that you can encounter, but luckily it's also the most or the rarest one of the different types of vascular malformation that we can see in patients with HHT. Now, because these diseases can cause so significant problems in the young age group, our opinion, which has been recently published in the American Journal of Neuroradiology, which is the largest journal in our field, is that there is a rationale for screening of children with hereditary hemorrhagic telangiectasia. It is not that if you have HHT, that like your child automatically has HHT. The likelihood is 50% though. Um, so we would recommend first genetic testing, but if genetic testing is positive, because it's such a potentially devastating disease, that screening is indeed indicated. And this differs, and I'm very transparent, with the screening rationale in Europe. In Europe, my colleagues, and I do come from Europe initially, say there is no rationale in doing this because A, anesthesia, which may be necessary to perform this screening in the very young kids, is necessary, and anesthesia has its side effects. Number two, treatment, even if we find something, is and can be dangerous. And number three, it is such a rare occurrence. To which our answer, when we published this, was number one, anesthesia has become so safe nowadays in 2026. Number two, treatment is actually now possible for these types of diseases, and I will show you later on a couple of examples. And number three, it is potentially such a devastating disease that we still recommend screening, which I think was one of the main questions that was asked. Now, um, here we'll show you an example of a patient that was screened and where we found indeed a large vascular malformation that you can see very nicely here. Again, compare this to the direct arteriovenous communication. There's the artery, here's the vein. Here's another example where we see the single dilated artery going into this massively dilated pouch. Here is an example of a patient who was not screened but then presented with a hemorrhage. There's the bleeding right here. There's a little bit of blood also in the ventricle. You can see the massively dilated pouch. It's really easy to identify. You don't need contrast. You just need a single, like T2 weighted sequence. This can be done really fast because it's either positive or negative. There's no in between, and the findings are not subtle. In this case here, we found there's one fistula there, one fistula there. This patient had three fistulas, of which one had actually bled. And the treatment can be done actually quite easily in these types of cases. Another example, this patient presented with neurological symptoms at the age of 2 years, and this was related to the fact that his venous outflow was already occluded and led to significant congestion of the brain. So the brain could no longer function normally, and therefore the patient had neurological symptoms. And here you see what we've did in this patient. We went with a small catheter, so-called microcatheter, all the way into this dilated artery. We deposited a liquid embolic agent that you can see here. And before treatment, after treatment, the vascular malformation was completely cured within a single session. This is another case that I treated when I was still back in Toronto. You can see this is not a subtle finding. This is very obvious. And in this case, we already see that there's some perifocal edema in the brain. And that's always a risk factor for impedant like hemorrhage. And so we went ahead and treated this fistula. This is before treatment. There's one fistula here. There's a second fistula up there. I go with my microcatheter just in front of this high flow fistula. I deposit the glue right here. I pull the catheter out, and this is before treatment, and this is immediately after treatment. And immediately, like after 3 months, the brain has completely remodeled, and the child was without any neurological symptoms after the treatment. This was a finding on fetal ultrasound, where on fetal ultrasound, this large fistula was found. And you can see again that we can go into this single artery. You see that the brain is no longer getting any oxygen. If this is not treated as the neonatal age, the brain will just like shrivel away because it does not get enough oxygen. This is immediately after treatment. You now see that the big vessel is occluded, but we see now the normal brain parenchyma filling normally. And on follow-up, the patient did fine and had no new deficit. So that was the second type of vascular manifestation in HHT. The third type are the cerebral nidus type AVM, i.e. this glomus, this tangle of abnormal vessels that we can see very nicely here, where often multiple feeding arteries are present. And this is a disease that is more of the like young adult age, interestingly enough, whereas the fistulas, they become symptomatic and they were like become apparent in the very young children. This is a disease that manifests itself only later on. And you can see here a couple of examples. We see that this is not a single whole fistula, but there is a conglomerate of abnormal vessels in between. And because it's embedded in the brain parenchyma, these types of vascular malformations can cause not only hemorrhages, but they can also cause seizures because they irritate the normal brain tissue, which is like hosting the AVM. Here you can see a microcatheter injection. You can see the microcatheter right here, and you see very nicely the draining vein here. You see the nidus of abnormal vessels in between the artery and the vein. This is your classical imaging feature of a nidus type AVM. And remember, they look so similar to those like vascular malformations that we do see in like the animal model. Patients with nidus type AVMs can either present with hemorrhage or with seizure, and the rupture risk is estimated at about 0.5% per lesion per year, which means that if you are, let's say, diagnosed when you are 30 years old and your life expectancy is at least 50 more years, and you own one, then the possibility of this AVM to at one point in time hemorrhage over your lifetime is in the range of 25%. And this has to be balanced against the risk of treatment that we will also speak about later on. One important feature is unfortunately this. They can occur de novo, i.e., if you were screened at, let's say, 15 years of age and everything looks okay, you may still develop a brain AVM later on. And this is likely related to the fact that, as I told you, our vessels are remodeling every 7 years. And this may mean that the blood vessel that carries the HHT gene mutation may actually get, due to a secondary hit that we will discuss about a little bit later, like manifest itself with the disease. And I will give you some example for this too. Here we have a patient who presented with a hemorrhage. You can see there's the bleed. You can see that we have one single dilated vessel, and there is the AVM with the focal outpouching pointing into the hemorrhagic cavity. There's the draining vein right here. You see the tangle of abnormal vessels. And this is something that we can also see here nicely on the 3D CTA and here on the angiography. And here you see our microcatheter going all the way into this distal blood vessel right here. You see the microcatheter is just in front of this abnormal tangle of vessels. And then we inject a liquid embolic agent. And this liquid embolic agent can then cure the AV. This is before treatment. This is after treatment with a complete cure of the AVM. Here another example of a patient who has presented with a bleed. There's the tangle of vessels. You can see the tangle of vessels here. You see the microcatheter here. We deposit the glue and the AVM is cured. Here you can see nicely the deposit of glue. Hold on. Sorry about this. The fourth and last type of vascular malformation are the capillary malformations. These are the most common vascular malformations that you see in patients with HHT. Capillary malformations are nearly always asymptomatic. In fact, from all of the cases that I have seen, I've only seen one patient who presented with a seizure in more than now me doing this for like the past 25 years. And there's one patient described in the literature who had a hemorrhage. And I'm still not 100% sure whether this was the case because these are not shunting lesions. You see just a tangle of vessels, but no early venous drainage within these capillary malformations. They are always small, and because they are asymptomatic, we see them very later on in life. So here you can see there, and you really have to look very carefully, or there is a capillary malformation right there, but no early venous drainage. Another example right there, no early venous drainage. And you can see them on MRI, and often people are afraid, oh, I have a vascular malformation. Does this now mean that I have a 0.5% risk of hemorrhage? In our opinion, no. In our opinion, these are nearly always asymptomatic. But the knowledge about these different types is not very widespread. So a general radiologist may call this an AVM, but in fact, it is just what we think is a capillary malformation. And at least in our center and in most other AVM centers, these are left alone because they are just simply virtually never symptomatic. Here, a couple of examples that we can see. You see that they are completely different from the other types of vascular malformations. We don't see a tangle of vessels, but we see a fluff of contrast enhancement. Um, and this fluff of contrast enhancement can only be seen on T1 post-contrast. And this is one of the reasons why I personally don't think that we should perform screening with T1 post-contrast images. Because the fistulas and the AVMs, you can see them very easily just with a T2 weighted sequence. If you give contrast, you may see these types of malformations and they just cause anxiety to the patient because they do not bleed in our experience. They are always, nearly always asymptomatic, and they are, in our opinion, leave me alone lesions. And here, just like another example for this type of capillary malformations. So, let's talk about some of the peculiarities. Number one, age dependency of different phenotypes. You already heard it, but this is just to show you again the age on a logarithmic scale. So this would be a neonate or like newborn baby on day one. This is like 1 year of age, 10 years of age, all the way to 100 years of age. And you can see that these capillary malformations, they are clustered around 30. AVMs are clustered around 20. The AV fistulas are all in the pediatric age group. Same for the spinal arteriovenous fistulas. Some of them in utero, some of them as a neonate. And what does this tell us? Do actually the AVFs vanish? Or, what I believe, do they become symptomatic earlier? And if there's only a specific window during the embryological life where the AVFs can develop, does it mean that in the mature vessels you will get only AVMs or the capillary malformations? Maybe. Second important item, multiplicity. Multiplicity in our series combined between Toronto and UCSF in sporadic AVMs, i.e., if you don't have HHT, was present in less than 1%. In patients with HHT, multiplicity was seen in 39% of patients. But remember, what are the most common ones? The capillary malformations. And these are the ones that are not at risk. This is something that we wrote up a couple of years ago. The multiplicity of brain AVMs is kind of predictive of the diagnosis of HHT. The third peculiarity that I would like to discuss is the different phenotypic expression despite the same mutation. So even though you may not have a brain AVM, your father, your mother, your brother, or your child may have a brain AVM, or you may have a capillary malformation, but your child may be born with a AV fistula. So despite having the same mutation, you can have different phenotypic expressions, as you can see in this case here. The next thing that we would like to discuss is the hemorrhagic risk. If you have a sporadic brain AVM, it is estimated to be approximately 2% per year. But in HHT patients, the risk is significantly lower. According to both the Bicetre and the like UCSF series, it's somewhere in the range of 0.7% per year. But why is this? Maybe it is because we are not only looking at the nidus type AVMs, but we are also subsumming all of those capillary malformations into the hemorrhagic risk group. And maybe because they have such a low risk, we falsely interpret the risk of the HHT AVMs to be too low, which would lead us maybe to a more proactive management for patient with true brain AVMs, not the capillary malformations. The last peculiarity that I would like to discuss, because before we go into the management, is the de novo formation of vascular malformations. And here, the important understanding that we have is that brain vascular malformations go through different stages. We see them as clinicians when the lesions becomes symptomatic due to hemorrhage or epilepsy. But before it's symptomatic, it's already visible as an incidental finding. What makes an AVM move from the morphological to the clinical stage? We don't know, but maybe it's biological changes, stenosis, hemodynamic stress. We will talk a little bit about inflammatory changes with the brain AVM. Prior to a morphological stage, however, we have a biological, genetical, and pre-pathological stage. And this sounds very abstract, but let me more clear for you right here. Let's say you have a cell, and the cell has a chromosome, and everything is still normal, so we are in the pre-pathological stage. Then, due to a primary or causative trigger, you get a mutation. And if the cell does not die, but continues to proliferate, it will have daughter cells that will constitute an organ. This organ, because it has an abnormal chromosome inside, because it has a mutation inside, is weaker than an organ that would be like having no chromosomal alteration. But it has not yet manifested itself with a brain AVM. So we believe that secondary or revealing trigger is necessary to move from the biological stage to the morphological stage where we have the brain with an AVM. So HHT, let's say you have a mutation in the endoglin gene. You have the disease HHT with the propensity to develop AVMs, but you may not be born with this AVM. But over the years, due to remodeling of the vessels every 7 years, at one point in time, you may get an asymptomatic AVM. And due to additional changes such as inflammation, venous narrowing, at one point in time, the AVM ruptures or the AVM presents with epilepsy. And here are a couple of examples. This patient was screened at age 10, and the brain is absolutely normal. But at age 16, right there, T2 weighted sequences, you see an abnormal blood vessel that was clearly not there before. So, de novo formation of an AVM. Here, T1 post-contrast, you see clearly abnormal vessels. Another patient at age 14, because of epistaxis, he got an angiography, normal angiography of the brain. At age 17, because of recurrent epistaxis, now we see an abnormal tangle of vessels right there. Now, do you have to be screened every year? Nope. I personally recommend our patients with HHT to be screened every 5 to 10 years. On average, 7 years, because this is your turnover of your normal endothelial cells. And we published this recently. De novo brain vascular malformations can happen in hereditary hemorrhagic telangiectasia. What is my personal approach to treat? I treat all pile AV fistulas. Number one, because they are easy to treat. It's a single artery, it's a single draining vein. That's something that we can easily treat. I personally do not treat the capillary malformations. There's one here, there's another one here. They all look the same. They look like a fluff of contrast, but no like shunting on the digital subtraction angiography. I leave those alone. And for those in between, the brain AVMs, we use an interdisciplinary approach. There are different ways to treat an AVM, and there is no one size fits them all approach. You should go to a center, if you have a brain AVM, that offers all four approaches. You need to have the possibility of radiosurgery, that's called gamma knife or LINAC, open vascular surgery, endovascular surgery or neurointerventional radiology or embolization, all the same word for going through the blood vessels. And to not forget, observation is also an opportunity. If you have an AVM where I have to tell you, honest to God, if I embolize you, you will have a risk of 30% of having a deficit afterwards. And let's say you are 55 years of age, you have 25 more years, your lifetime expectancy of this AVM to rupture is somewhere in the range of 12%. I'm actually more likely to harm you than the brain AVM. So observation is a true alternative to like the more active management. We sometimes do a multidisciplinary approach. So for example, I go ahead and do an embolization, which is then followed by radiosurgery. Or we perform radiosurgery, we shrink the AVM, and the remainder is being taken out by open surgery. So therefore, you have to be in a center that offers all treatment opportunities. And we strongly recommend a center of excellence that knows what they are doing with these types of vascular malformation. Final, maybe 10 minutes so that we'll have enough time for questions. Novel therapeutic options. We will go through new embolic agents, new techniques, new materials, new approaches, and then the very interesting biological treatments or anti-inflammatory medications, and maybe a little bit like a look into the future of in utero treatment. So let's start off with the new embolic agents. In the past, we only had glue or NBCA. Now we have onyx, fill, squid, and there are some good things about glue, as I can show you here. Patient relatively old already, but he presented with new seizures, progressive cognitive decline, and we can see here a large AVM that we went in with the microcatheter session 1, got it already much smaller. After session 2, significantly smaller, and then we were able to actually completely obliterate it after 3 months. And you see that the patient is now completely cured from his AVM with just this deposition of glue within the AVM. This was before, this is the glue deposition, this is after, with the patient being cured. Or here, an example of a patient with an AVM in the cerebellum, feeding artery 1 and 2. Right here, we go with our microcatheter all the way towards the fluff of abnormal vessels. And here you can see the real-time injection. This is as fast as we can do it. You see that the glue comes in, closes off the AVM, goes into the vein, and refluxes now here into the second artery right there. In this moment, I pull this out and within literally 30 seconds of embolization time, the patient is cured without having to open the skull, as we can see in this example here. This was a patient with HHT who again was screened, and we found this AVM here, very simple and easy to see. And what I really did not like was that this patient had a focal outpouching right there, a big outpouching. This is something that is very dangerous. This is something that tells us this is about to rupture. So we can't wait for the gamma knife or the LINAC because it takes 4 years to work. So either we go in for open surgery or we treat the focal area of weakness by embolization. So this is before treatment, and after treatment, you see that I've taken out the aneurysm, and now the AVM is no longer dangerous. So we treated the remainder of the AVM with gamma knife, and this is the patient before treatment, and after treatment, you see that the patient's AVM is completely cured without having to crack open the skull, and the patient had no new deficits. There are certain peculiarities that I will not go into, but just to tell you briefly, there is also now the possibility of new liquid embolic agents. Here we had a patient who presented with his first ever seizure. We see the tangle of vessels right there. We see a large outpouching here. This is something that we are really afraid of. We go in with a microcatheter here and inject this onyx that really casts the entire AVM. And this is the same patient at the end of the procedure. We have now completely cured the AVM in this patient. Okay, what about new techniques? Very briefly, we have now the possibility of preventing us from having too much reflux. Patient here with a brain AVM. We see there's the feeding artery. We go in with like two catheters side by side, put a couple of coils in there, and these coils prevent the onyx to going back on us into normal brain tissue, and I can therefore only push the onyx forward into the brain AVM, completely casting the AVM without risking any reflux towards normal brain. And this is the final angiogram, and you can see here nicely that the patient is cured. This is the MRI, no deficit in the brain, no stroke, and this is the 3 months follow-up with a very nice result. Mini balloons are like the latest gadget that we use, and they are really nice. They are extremely small. They are like less than a fraction of a millimeter in size, and they allow us to go into these very far distal vessels. In this case here, you see there's a vessel coming off that is going to normal brain parenchyma here. But this vessel and this vessel are still feeding the AVM, so our reflux margin is really small. And in these cases, I need to ensure that I will not like get my onyx into like the normal vessel, because then the patient will be plegic. So you see that we are here all the way now with this micro balloon. We inflate the balloon right there. You can see how tortuous the route was, but these balloons go very far into the distality. We inflate the balloon. This is without the balloon inflated. This is with the balloon inflated. I now have complete control over my flow when I'm injecting the material. And you see here that the patient's AVM is completely cured after the treatment, with this being the onyx cast without any abnormal onyx in the normal brain. And this is the 3 months follow-up, which was done under local. Therefore, the patient moved a little bit, but you see that the AVM is completely cured. And here we had a patient who had a field deficit. We see the AVM right there. We go in there with the balloon, and we can cast very exactly the AVM proper, leading to complete obliteration of the AVM here and no deficit afterwards. transvenous approaches. If we can go from the back door, from the front door towards the back, we can also go from the back door towards the front, i.e., I go from the vein and now inject the contrast material into the nidus from not the artery, but from the vein. And so I just use a transvenous approach. Here's an example, patient with a bled AVM. We go into the AVM not from the front door because we see only here en passage feeding vessels with a normal artery still going towards the brain. So you can't take this from the arterial side, but you can take it from the venous side. So we see here our setup with all of our different catheters going inside to control the flow. We have a balloon up there. So here we are going up, up, up through the veins into the AVM. Here we put our balloon into the artery. We inflate the balloon right here and start to inject the onyx, closing off the entire AVM while protecting the normal artery. You see the normal artery is preserved, the AVM is cured, and the patient had no deficit and his AVM was cured. This is before and after, no evidence for any hemorrhage or ischemia. Another example here of an 57-year-old woman, where we see here the transvenous, here the foot of the vein. Here's our microcatheter in the vein. We blow a balloon up, we inject the onyx. Here you see the balloon in the artery. We inject the onyx. There's the final cast, and the AVM is gone. For the sake of time, I will skip this example to go now towards biological treatments. The rationale is, as I told you, we have in HHT a problem between the activation and the resolution phase, i.e., a problem of the angiogenic switch. And what our colleagues at the UCSF has found is that it's not only the missing ALK, but what causes an AVM is that you have to have the mutation, but your revealing trigger is that you have an increase in vascular endothelial growth factor. And this helps us now to maybe treat patients, because if you have a mutation in ALK1 but no vascular endothelial growth factor, there's no AVM that is being formed. So maybe, just maybe, what we can do in patients with HHT is to block ALK1 or endoglin through an vascular endothelial growth factor blockage. So maybe anti-angiogenic drugs may be the future, at least in the rat model. When we inject avastin, which blocks VEGF, we can see that the AVM has actually regressed over time. Now, there are lots of open questions there. We do know that even in sporadic AVMs, MEK inhibitors work. We can identify through microRNA signature what type of vascular malformations we are having, as in this example, using so-called liquid biopsies. But there are lots of open questions still. Can AVMs really in humans regress? In the animals, it appears to be the case. But what are the side effects, in particular in the growing body, i.e., if you have kids with vascular malformations? So I would think that in 5, 10, 15 years, maybe will be moving towards this, but we are not there yet. But what about anti-inflammatory medication? So this is work that comes from our knowledge of why aneurysms rupture. Aneurysms can rupture due to a pro-inflammatory response within the vessel wall. And together with my colleagues in Finland, we looked at whether in brain AVMs we also have inflammatory changes. And indeed, what we found was that within the wall of brain AVMs, there are inflammatory changes present, which may mean that in the future, to prevent an AVM from rupturing, we may need to give anti-inflammatory, for example, COX, to be antagonists. Again, we are not there yet, but it could be an interesting like pathway towards treatment. The final one where also, again, we are not there yet, but we at least have now FDA clearance. I am working not only here in Boston, but I'm also affiliated with the University of Texas as an associate professor or an adjunct professor, actually, at the University of Texas at the Baylor College of Medicine and Texas Children's Hospital. And together with Texas Children's Hospital, we have developed a technique of in utero treatment. So here you can see me together with my colleagues that are both open surgeons, cardiologists, and fetal cardiac surgeons. And what we are doing is we are accentuating the uterus. We are identifying where the heart is with ultrasound. And while the baby is still in utero, we are puncturing through the placenta the heart. And here you can see how our needle enters into the heart. We put a wire through the needle, and now we have access to the entire fetus while the fetus is still in utero. And here we can treat now a vascular malformation and then take everything out, put the uterus back into the mother, and have the child be born at a normal gestational age. If you are interested in these, I would welcome you to our annual Interventional Neuroradiology Symposium, which will be held in September in Cambridge, here in Boston. Here's the website in this QR code. And on this QR code, you will find all of the articles that I have written on HHT over the years. By now, more than 26 scientific articles, and you will see like where we are currently standing in HHT research for vascular malformations of the brain. This is my team. We are a dedicated HHT center here for at the Leahy Clinic. If you have any questions, here's my email. And with this, I would like to thank you very much for your attention, and I hope we'll have enough time for questions.
Thank you, Dr. Krings. That was quite fascinating. And that video at the end, the in vitro procedure is pretty remarkable. That's really incredible. So we did have some questions. We had a couple of patients, several actually, that posted in our Q&A about Gamma knife procedure. Can you just speak a little bit about that?
Okay, Gamma knife is an outpatient, or also LINAC. Both are equivalent. It's done as an outpatient. On the day of the procedure, you classically get an MRI, a CTA, and a digital subtraction angiography. All of this data is being merged together on a workstation, and the person who is planning the treatment is then delineating where the AVM is. The Gamma knife works like this. You are having a helmet on top, and each, like you have multiple sources that all converge in where the AVM is, and only there. And at this location where the AVM is, the maximum dose is deposited. And this leads to like proliferation of your endothelial cells that then shrink the AVM over time. Works in more than 85% of patients. Um, uh, it does take 3 to 4 years to work. it has to have a certain size. If it's too big, you can't do it. And there's potential downside of radiation-induced problems.
Mm, thank you. What about you mentioned about we talked about screening and seeing brain AVMs at different stages of life. How often do people should they get screened if they have an AVM, a brain AVM, and it's just something we're observing? How should it be observed, and how often should they get screened?
So from our perspective, it's like we recommend every 7 years. And this is just due to the simple biological fact that endothelial cells, on average, like turn over every 7 years.
Mhm. Okay. And so one of the other questions we had is what about signs of any kind of AVM maybe enlarging or potentially possibly rupturing or could be rupturing? Are there signs that people should be aware of that might lead them to think that, hey, this is something I need to get checked. This is getting serious.
So any type of new symptoms, we would recommend getting checked, and that is new onset of seizures, new onset of a neurological deficit. Then we would recommend earlier check on the AVM.
Okay. And I'm going to do one more question because we're getting near the end of our time. If someone was diagnosed with a brain AVM and it was, let's say it was 20 years ago and it's been monitored, so forth, what was the growth rate you were talking about? Could it potentially grow? Um, it,
In our series, in this article that I had shown previously, we had one patient where the AVM grew, but the this is rare. This is extremely rare. That's the only single case that I've seen where I've seen brain AVM growth over time. The majority of cases, they are stable.
Right. Well, thank you so much for your time today, Dr. Krings. We're at the 4 o'clock hour and we want to be cognizant of your time. So thank you so much for all of this information. It was really super helpful for everyone. And we appreciate everyone attending today. Again, there will be a recording of the webinar so you can watch that and get back to all those little details that Dr. Krings shared. So thank you so much.
Thank you. Take care.